Thanks for coming, guys. Today we're going to go over my site impact review. The main purpose of this is just to give the impact of this residency that I've had over the last 2 years for St. James Sports Medicine while at Butte High. So we're going to talk a little bit about my residency review, some of the data, and then just share my experiences with some of the outcomes. So to start with the demographics, I saw mostly male patients, most of them being football players, and then kind of a variety of the other sports as well. And then when we start to break down the types of patients I was seeing, almost half of them were muscle strains. We see a lot of that at the high school. Followed by tendonitis and ligament sprains were kind of close together, and then everything else kind of fit into some other category. The location was mostly in the hip and shoulders, but then we also had quite a few ankle and knee injuries as well. So just a couple of notes on this. These patients are all from Butte High. We treat by appointment in the mornings, and then kind of a first come first serve in the evening or in the afternoons. So there are 2 of us. I did not collect data on every single patient who walked in the clinic. So when you start to see these numbers, just kind of keep that in mind. So kind of my journey through collecting outcomes. So we started out, the doctorate program has us, gives us kind of an overview of a bunch of different ones. And I was super gung-ho. My first semester last fall, I said, I'm going to collect all of these outcomes. They're super important. So I looked at the numeric pain rating scale, the patient-specific functional scale, the GROC, the DPAS. I saw a bunch of them. And what I realized come the end of the semester is I was not organized enough to collect them in a meaningful way. So it was hard to then interpret anything that I had throughout that semester. So semester 2, I tried to increase the quality and decrease the number, went mainly for pain, and then the disability and the physically active scale, just so that I could start to organize things better, get a feel for what kind of patients I'm seeing and what kind of outcomes I'm seeing. And then last semester, I started to feel better organized, was getting good pain and functional scales. And then Erin, my attending clinician, and I kind of met. We were really talking about what kind of outcomes do you find to tell a story about what patient care we're giving at St. James. So we started to collect things like time to discharge, time lost, and then start to look at limited participation, just so that we could give that kind of information to different parties. So we're first going to talk about the pain scale. This is my favorite pain scale. It is not the one I used. In order to be consistent, 0 was have no pain whatsoever, and 10 was take me to the emergency room. But this is my favorite pain scale. All right, so what did we learn over the last 2 years talking about pain? So there's lots of numbers up here, but what we're really looking at is kind of the means. The worst pain was obviously the mean was the highest, which was almost double what they normally see at rest. And so we kind of want to take a look at that. So if they come in and they say, yeah, it hurts at about a 3 right now, well, yeah, but when I'm running, it hurts a 6. So once we look at post-pain, we're talking 1 treatment. After 1 treatment, their pain at worst decreased, and their pain at rest, it got even lower than that. So when we start to look at the follow-up, we're looking at the, it's actually a little bit higher, not a whole bunch higher in the means from the post-treatment. So a couple people, the treatment held pretty well. A couple people, their pain starts to return. And then when we're talking about the days to follow up, that's right around 1 to 2 days. And then we look at by a lot after 1 day of treatment. A change of about 2 is something that the patient actually feels. So what's meaningful to clinically? So we're looking at about 51% of the patients met that MCID after one single treatment. We're looking at about 97% of the patients met that MCID when we're comparing that worst pain to post-treatment pain in one treatment. When we start to look at discharge, we're looking at about 84% of the patients that met that MCID when we're comparing to the pain at rest to pain at discharge. And then when we start to look at that worst pain to pain at discharge, we're looking at 98% of the patients I saw in the last 2 years had a clinically meaningful difference in that about a week's worth of time. So we're making clinical changes in pain. The next thing I looked at was the patient-specific functional scale. I really like this scale because we don't want to just decrease pain. These are athletes. We want to make sure that they can go perform whatever function they want to. So in this scale, the patient identifies 2 to 3 actions that they feel are impaired due to their injury, and then they get to rate it. 0 being unable to perform the activity at all, 10 being they can perform it with no problems, which is a little bit hard in high school because this is flip-flopped from the NRS scale. So it's a little bit, we have to make sure that we really kind of communicate with our patients to make sure they understand what we're asking of them. So in my patient population, some of the more commonly used functional impairments that they talked about was running. I had about 54% of my patients looked at running as one of their impairments. 23 identified squats or cutting motions, and then about 15% identified walking. They were identifying 2 to 3 of those, so yes, this adds up to more than 100% because they might have had multiple ones. All right, so what did we find? This is a really busy slide, but I wanted to kind of give you guys an idea of some of the things that they gave me. So if they identified going upstairs and they rated it as 7 and they rated their squats at a 5, we take an average of those two, and this blue column is their pre-treatment. And then their the post-treatment, which is the discharge treatment, is in this other blue. So kind of look at those blue columns. So we're taking a look at those average, and then we're looking at how much did they change from when they entered to when we discharged them. So that last column is the most important one. We're looking at how much did they change. The MCID for the PSFS, when we're looking at the average from pre to discharge, is 3. So we had 7 of the 13, or 54% of them, saw meaningful changes after seeing athletic training services at Butte High. So we start to look and say, well, that's just over 50%. Well, the other 5 people that did not necessarily meet the 3 for minimal clinical change were all above 2, which is good. And then you start to look at the average of what those 5 people averaged at the end. What was their function when we finished? Their average is about 8.26. So they're fairly functional by the end, even though they didn't change that much. So that means that they probably started at a little bit higher function than the rest of them. So I still think that those patients saw good, meaningful change seeing us, even though they started at a little bit higher level of function. All right, so we looked at pain and we looked at function. I also looked at the disability and the physically active scale. The goal of this scale is to really look at impairments, disabilities, quality of life, and then functional limitations. So I had a mean score 28-ish pre, and a post score of 16, so that change is about 11. One of the things that we had an opportunity to do last semester was they asked for class, we were asked to look at the DPAC on a healthy population, so we can start to kind of compare what do people normally look like when they're answering, especially the quality of life, functional limitations type questions. So I had one patient who was in my healthy population, and he scored a 4, so he had barely any limitations, didn't really identify with anything. And then about 2 weeks later, he hurt himself in football. And so we took an initial, and he scored a 27. So lots of things on the scale kind of changed for him, especially the quality of life ones. And then we started to look at discharge. So his pain and his function went to what we would normally say is discharge level. And then I still gave him the DPAS to start to look at some of those other qualities. And he changed. He had a meaningful change. He changed by 10. That's fantastic. But one of the things that I noticed was that the physical stuff, the disability things, he was low at healthy, he increased during injury, decreased at discharge. When we start to look at the well-being, there was things like that was not quite as expected. He was no problem, he rated things as no problem on stress, pressure, and anxiety. He rated low at healthy for altered relationships. And then both of these increased a little bit, as well as the mood changes went to slight. So he had these kind of other qualities to his life that he felt the injury was affecting. At the time of discharge, only the well-being scores that decreased was the altered relationships. All the others remained at that slight or problematic viewpoint. So one of the things that I learned from utilizing this, especially the DPAS, was that we may look at the physical attributes to return somebody to play, but it's really important to start looking at some of those well-being things as well, kind of an overall health and wellness, because those things may not go back to what we consider a healthy level post-injury. So those are the main outcomes that I looked at. So I'm going to look at this from a couple of different viewpoints now. One being, let's look at it from our viewpoint, from an athletic trainer's viewpoint. So outcomes that we saw on pain, function, and disability. Some good changes in pain. We got quick functional changes. And so when you start to look at those things, you go, so I had 42% of my patients came in with muscle strains, and then 24 of them with tendinitis. We're looking at tendinitis as kind of a chronic thing. We base it off of the signs and symptoms and the mechanism, right? But then I get them to change in one treatment in a meaningful way and back out to play. So from an athletic training point of view, I kind of had to stop it and say, do I really think that somebody that came in with tendinitis that I changed in one treatment had tendinitis? Or is there some other thing that's going on? Is the tendinitis caused by a mechanical issue in the joint? And if we fix that, then the pain goes away. You know, those types of questions that come up is kind of the things that I reflect back looking at those things. Like, yay, that's fantastic, we made a meaningful change, but what does that do to my practice? I'm trying to figure out, is there a better way for me to maybe describe those ones? We can't really do that with what the data I have right now. So some of the things that we need to look at in the future, we just need more data. And then it'd be nice to be able to look at kind of a homogeneous population. So is there something that all those people that came in that changed in one treatment, do they have something in common? And the people that maybe don't change in one treatment, do they have something else in common? That we can, as clinicians, then say, oh, I think I identified you as somebody who would benefit from this treatment, and it would probably be a fairly quick, easy treatment. Or do we need to take a little bit more time on this? So one way to look at this, I kind of broke down two of the main types of treatments that I use. The Mulligan concept has a theory of a positional fault. So I was talking about that mechanical issue. The Mulligan concept usually goes at a mechanical issue at the joint level. The other one that I used quite a bit was the primal reflex release technique, which has a theory of kind of an upregulated autonomic nervous system. So we're looking at that's triggering pain or muscle guarding, that sort of thing. So if we can downregulate the system, we can see a change in a fairly quick amount of time. So if these theories might help explain a little bit more, I kind of look in depth on these two paradigms by themselves. So they carry the same overall theme as the rest of my pain scores, but if we're looking at pain with the Mulligan concept, we're seeing a mean change of about 4.45 And then to discharge, we're looking at almost a 5 to 6 point change overall using the Mulligan concept. We're still using the same data, meaning that like the week-long average for discharge is still applicable. PRRT, we had a little bit less people, but the change was still significant, right at 4.5, from worst to post-treatment. So we're talking 1 treatment, and then to discharge, we're looking at an overall of about 6. So that's kind of the way I reflect on it for our population, but then to be able to take this information and disseminate it to other populations, including our patients. So patients normally walk into our office and they ask, when is my pain going to go away? Will I be able to play again? And how long until I can play again, right? So when we start to look at this data, we have a change in pain after 1 treatment is significant, and the change in pain at discharge is significant. So will their pain go away? Yes. Changes in function, will they be able to play again? We're seeing an average functional score of about 8 to 9 at the end. That's a pretty high functioning level. So after treatment, we can say, yes, we're going to work to get you functional again. And then the return to play time is that average of about 6 days. Now that's going to change, kind of from one location to the next, but it's nice to be able to have a good answer for the patient population. Another population that cares about these injury stats is the coaches. I feel like if a coach can understand the type of care an athletic trainer is capable of addressing, they can not only know when to send them, but also teach the high schoolers when best to see us. So we're looking at the majority being strains, and tendonitis and sprains. So if somebody walks up to a coach and says, hey, my muscle, I think I pulled my muscle, the coach then feels comfortable sending them to us. Specific locations, we have a good change in pain regardless on hips. So hip, shoulders, and ankles were my main ones, so I kind of broke those ones down. And we're looking at the follow-up time for a hip pain is about 2 days, and or it's about a day, and the pain at follow-up is about a 2. That's a pretty good, meaningful change if somebody walks up to a coach saying, hey, I think my hip or my low back kind of hurts. Same thing with the shoulder. We're seeing that the pain on average is about a 1 at the end of about 1 to 2 days. An ankle is even better, pain of about 1 after even less than 2 days. We always try to send those ankles to us and get those feeling better. So again, coaches just making sure that they know, hey, if you send them to us, we're not going to have them out for a month. We're on average about a week, and quite a few times we're less than that. And last, St. James, what kind of the implications for us as a program? So our mission statement here at St. James is improving the health of the people in the communities we serve, especially those who are poor and vulnerable. So I think the results of this site impact really kind of shows that the athletic trainer out in the community, we're not charging per patient, we go through the school system. We're really meeting that mission. We're able to provide meaningful changes at a clinical level out in the community. And then if we look at our goals kind of to grow throughout the community, I think we have positive anecdotal information right now, support throughout the community. And I just think outcomes and data may also be more powerful when we start to go and say, we're trying to look at expanding. These are the types of services we provide, and this is the type of outcomes we're getting. So somebody, like if we're looking at another high school and they say, well, I think you should only be here for games, we can start to say the more that we're there, and if we have more treatments, then we can start to look at better overall patient care. All right. So quick thank yous, Chris and Holly, for allowing me to do my residency here at St. James. Butte High for allowing me to do most of my patient care there. Erin as my attending clinician, and Christine as my coworker over at Butte High. So at this time, questions. That was a lot of data in one fell swoop.
I don't have a question, but I have another comment.
Okay.
As a benefit, that you and your program and this program has, is, just the knowledge that Butte High appreciates what we do so much, that they're actually looking at hiring a third athletic trainer for school district number 1 to be a full-time between Butte High and East, and that is again due to the great work that you two are doing at Butte High, and the great work that our whole team does in the community, so, I think Maisie's point of, you know, us providing great clinical care does benefit not just St. James, but our entire community.
Go team. Any other questions, comments?
Has your coaching staff saw a great increase in you coming to, with numbers to them? Are they more understandable about injuries and pushing athletes towards you to get care?
Yes, step by step. There's some coaches who are already on board, and they understand those types of things. But the nice thing is sometimes when you break those things down, like, hey, when I see a hip injury, this is the type of outcomes we're getting. They go, oh, I didn't think you could treat that. So there's some, that's really been nice to be able to kind of break it down either by location or like the type of injury. That seems to be a little bit more powerful than, hey, we can do a really good job, or even the overall pain. Okay, yeah, you can change pain. But when you give them those specifics, that's when it has seemed to make the biggest difference with coaches.
Then how about with fellow athletes? Do you see athletes telling other athletes, oh hey, Maisie fixed that on me last week, you should go see her?
Yes, very much so. Yeah, especially specific injuries, like, oh yeah, I had that, go there. When they come and see me, it might not be the same thing, even though it's the same location, same type of thing, but we can still treat it, and that's what's been really nice.